It is the optimizing of a game changer to overcome the clinical barriers. ये optimization किस चीज़ की है? Obviously, being a physician, the management is with the medications. The second thing is the clinical barriers. We all know that we know, and we try to know our level best. But how much it impacts our practice? The practice essentials. Yesterday night we got a sumptuous dinner. After the talks, a brilliant talk, lastly but not leastly for Professor Javed Akram, and we saw after that how much we got the message. So this is how actually it is. So it is again an effort, and thanks Ahmed Shahzad sir, who is always doing something, and it is for him that we all, most of us like me, is here at Faisalabad. Excellent host and excellent teamwork. With that, I start my topic. Diabetes is spiraling out of control. ये लफ्ज़ मैंने कहाँ से चुराया? ये 2021 की जो लास्ट एटलस है, 10th एटलस ऑफ IDF, मैंने वहीं से लेके छाप दिया यहाँ. रीज़न ये कि इस काफ़ी अट्रैक्टिव और काफ़ी कैची था ये. Then the second point that it makes, it doesn't put that impact from the morning, afternoon yesterday and morning today. We all know that we got pre-diabetic people are rising, we got diabetic population of more than 500 million, and we are expecting to make it rise. It will raise until we have got the impact of our knowledge coming into our practice, which probably is a bit difficult. So I must recommend that sessions like such should have behavioral therapists, psychiatrists also in it to give their expert comment how to make things really practically done. Then the third thing, where the Pakistan is. The Pakistan population in 2021 data showing that in adult population of more than 123,000, in fact it is more than a 12 million, prevalence of diabetes in adult is 26.7%. Now it has been updated, 33 point some figure has been the percentage where the prevalence of in adult population the diabetes type 2 is. And the other thing that we know that what type of population all across globe, we can divide them into 5 different clinical cohorts. And what actually this approach attracts me to is that it gives you real-time management points where to place your patient that you face in your clinic. There is a type known as severe insulin deficient diabetes, which include autoimmune and non-autoimmune type. There is severe insulin resistant diabetes. There is mild obesity related diabetes, which we can debate whether it is mild in our population or not. And there is a mild age related diabetes, which we again debate over the word mild. But it has been classified. So there are 5 varieties. 4, because it is one autoimmune dependent insulin deficiency, the other is severe insulin deficiency without autoimmune. So in first case, there are 2 types, and the other 3 concluded to become 5 types altogether. अब इसमें इम्पॉर्टेंट पॉइंट क्या है? इम्पॉर्टेंट पॉइंट ये है कि अगर हम शुरू में क्लासीफाई कर लें, सो वी कैन मेक पीपल क्लासिफाइड इनटू प्योरली predominantly insulinogenic population and predominantly insulin resistant population. So we can easily make our choices right at the beginning. People who are presenting themselves with polyuria, polydipsia, polyphagia, they are type 2 diabetes, not type 1. And these are the feature of type 1 diabetes. So they actually are the one who needs as a one component besides all other dietary, behavioral, lifestyle management, metformin or maybe SGLT2 inhibitor. They are the one who should have at least insulin as the pivotal pillar in their management. So if it is being classified early in the course, then it would be easy. People who are losing weight without any reason and they are diabetic. People who they got their first sugar coming more than 300, random sugar. They are the one who should be picked up as the cases where insulin is mandatory as a part of their management, besides all other things that are needed. While the rest are having predominant insulin resistance. So What we need in those cases, obviously, some sort of other approach besides insulin to help us out. If you take 2009, the Franzo model of type 2 diabetes, it gives you ominous octet, 8 defect. None of our current medication alone fix all the 8 defect. So we have to have something new in our approach right at the beginning. The first thing that I have shown in the previous slide, and now we have to think that how we should be approaching to change the game, to make it really a game changer. We as a clinician, me also and you also as a clinician, we used to classify medication according to our needs. And what are the needs? The needs for diabetic control was, in oral agents, we need the agents which can control the postprandial sugars, all the agents, the groups. We also got the need to convert our preprandial sugars controlled with metformin and SGLT2 inhibitors. And we also got agents which are oral agents, but they are controlling both pre-meals and post-meal sugars. Out of this lot, if you take the ominous octet, as the pathophysiology of type 2 diabetes, you can easily classify that if you take these agents, metformin, DPP4 and SGLT2 inhibitors together in a one go, it will shift all ominous octet pathophysiological points together in a one pill. And if that pill is easily disolatable, if that pill is not larger in size, not having corners, and got good quality, you really try to hit very hard right at the beginning. And if you have classified your patient primarily that they are insulin deficient, you can add insulin to it. One pill, one injection. And it will settle most of our cases. Not all, but most of our cases. So we are going to see. यार बहुत शुक्रिया. ये पहला माइक है कि जिसमें मुझे कम बोलना पड़ेगा जितना उसके लिए मुझे जोर लगाना पड़ेगा. So most of us see that if you got a combination, we need to know the profile of each agent. And we can see that from this, ये नीचे reference नजर नहीं आ रहा, the latest reference of 2022 or 23. This reference shows that the mechanism of metformin, more than 65 years have been evoluted since the metformin has been invented. And we still need to know more and more with the passage of time that how much and how well that drug is functioning. And we can easily see that it affects liver, it affects GI, and it decreases the inflammation. The last session that I was sharing, there was systemic inflammation on which the Dr. Ali Arif was actually emphasizing. Chronic inflammation. And that inflammation reflects in terms of vasculitis, small, medium, and large. And that has been already the feature, the pathophysiological definition of diabetes itself. If you want to define diabetes pathophysiologically, it is purely a vasculitic event. So with metformin, you decreases the systemic inflammation. In liver, it decreases gluconeogenesis, decreases lipogenesis, and in GI, it basically increases the glucose utilization and it increases the GLP-1 secretion. Secondarily, what are the indications in which the metformin shows its promise? You can see cancers besides diabetes. You can see disorders, genetic disorders like Down syndrome, degenerative disorders. You can see aging defects that can be fulfilled, cardiovascular benefit, reproduction. We all know that how much it impacts in the PCO patient, how much it impacts obese male individual in restoring their and good quality of semen. If you again come on to the same slide, what's the second agent? The second agent is a group taken as DPP4 inhibitors. And what promises that DPP4 inhibition provides you? It increases GLP-GIP production through pancreas, ultimately increasing insulin, decreasing blood sugar. On the other hand, it has got a direct cardiovascular benefit, the GLP-GIP. If you got a DPP inhibition, besides GLP-GIP benefit, you got increased BNP levels producing diuresis, increasing stromal drive factor, and substance P, which increases angiogenesis, and apoptosis and fibrosis get decreased. So all the promises that you can see as a biological consequences of DPP-4 inhibition. So what are actually the mechanism? Decreased atherosclerosis by DPP-4 and myocardial infarction protection. These are the two benefits that clinically it translates. Then if you talk about cardiovascular protective effect of one of an agent, which is linagliptin, out of the lot of DPP-4, already Dr. Kammer Masood, Professor Kammer Masood from Aga Khan University has alluded in the previous session that what does it produce? It has got the added advantage that it is being excreted by liver and kidneys both. So it has got no dose modification, and it has got no dose increment according to the EGFR or according to body weight. You only need to give 5 milligram. थोड़ा सा इस तारों को जरा बचा लेंगे तो काम अच्छा रहेगा. So the final thing I would say with the linagliptin is cardioprotection. The other thing is renal protection, protection from stroke, and protection in retinopathy. All the end organ damages that we really get feared managing diabetes are being provided with DPP-4 inhibition, particularly the linagliptin. Then we come on to the third group, but last but not the least, the SGLT2 inhibitor. SGLT2 inhibitor has got a potential risk target benefits, and that is the very busy slide. Whosoever can recall, I could not in one go, but you can got all the benefited point actually get hand-to-hand benefits with SGLT2 inhibition. And with that, it also got role to play in diastolic dysfunction of preserved ejection fraction heart failure. Very few drugs, very few drugs are being benefiting the preserved ejection fraction heart failure, and it is one of the most potent drugs that we know that it has got a role to play for preserved ejection fraction heart failure because it has improved the diastolic function of the heart. Then renal benefits, we all can see what's the benefit the EMPA-REG trial result has provided. Composite progression to urine albumin creatinine ratio of more than 3, you got actually event prevention of 39% relative risk reduction, and doubling the serum creatinine you got nearly 50%, 44% to be precise, relative risk reduction. So you got a promise in patients who are having chronic renal failure along with diabetes to get benefit with this agent. If you combine the two, the SGLT2 inhibitor and DPP-4, you can easily see that it ends up into decreased inflammation, decreased oxidative stress, decreased fibrosis, particularly in cardiovascular system, the heart, so to improve cardiac function of the heart. If you take combination of EMPA and LINA, one of the agents from each group, EMPA from the SGLT2 inhibition and LINA from DPP-4 inhibitory drugs, you got the benefit that there is a change from baseline HbA1c at 24 weeks, which is much higher than the individual group usage. If you take people who are having more than 7% HbA1c and bring them down to less than 7% HbA1c level, the combination provides both in both strength, 10 and 25, both strength of EMPA, the benefit of combining it with the LINA. If you talk about fasting blood glucose bringing down, again the combination has got much more promise in both strength 10 and 25 than the individual agents being studied together. If you want to see the body weight reduction, because we got a holistic approach to treat diabetic patient type 2, it again got the same type of benefits that it shows in HbA1c and weight and fasting sugars. So we got synergistic effect. Synergistic as a complementary mechanism. We got improved glycemic control. We got that combined to translate it itself into more patient adherence. Reduce side effect because we need not to give larger amount and reduce the cost as well. So at the end, The comprehensive diabetic management, cardiovascular and renal protection are needed besides controlling the figures of HbA1c and sugars. So we got more benefit with targeting a combination of drug in a single pill. You got different type of strength available for the combination. For once daily dosage, you got 10 and 25 combination of AMPA with different strength of metformin, like 1000 mg and 5 mg of Lina and metformin. You got in lower strength twice daily regime, 12.5, 2.5 with 1000 or 5, 2.5 with 1000 available and recommended. With that, I thanks my audience for patiently listening. The Q&A at the end?
Yes, we will have the question answer session after all the presentation, depending upon the availability of time. Thank you.